going to be reading the bio of Dr. Otene Samuel, who is going to be taking us on cancer, giving us an overview of cancer and all it entails. So Dr. Otene Samuel Anaja is a medical doctor and radiation clinical oncologist. He's a cancer specialist. He's 48 years old. He obtained his medical degree in Ahmadu Bello University, Zaria, and his postgraduate fellowship in the National Postgraduate Medical College of Nigeria, as well as a few other countries. Since 2012 till date, he has remained the only consultant radiation and clinical oncologist in Benue State. He is currently a senior lecturer at the Federal University of Health Sciences, Otukpo. Until recently, he was a chief consultant and the head of Department Oncology and Palliative Care Department at Federal Medical Center, Makurdi. He's also a visiting consultant to Benue State University Teaching Hospital and visiting lecturer at the College of Health Sciences, Benue State University, on oncology-related topics. He is the immediate past national president of Hospice and Palliative Care Association of Nigeria, HPCAN, as well as immediate past chairman of Nigeria Medical Association, Benue State Branch. Currently, he is the national chairman of NMA, National Committee of Cancer Awareness, Prevention and Treatment Guidelines. He has won multiple awards, both at state, national, and international levels. He is married to Mrs. Rebecca Uyo Sam Otene and has 5 children. He loves to read, write, and sing. Also loves football and basketball. He lives in Makurdi, Benue State. Please, let's put our hands together as we make welcome Dr. Otene Samuel as he takes us on cancer, giving us an overview. Dr. Samuel Otene, you're welcome, please.
Thank you very much. I hope I'm audible.
Yes, please, you are.
Am I audible?
Yes, sir.
Oh, thank you. Good morning, everybody. I want to appreciate the Executive Director of C-Help, Dr. Margaret Popola. From just little tinders and embers, C-Help has been able to grow to become the global conflagration that it is right now. You have done well. I appreciate you, and I count it a rare privilege to be one of those that will speak here today. I am conscious of time, but when you are speaking and your teachers are there, you must take at least a few seconds to recognize them. Professor Onwaso is not just my teacher, she's a mother. Professor Ahmed,
I think he's experiencing some technical challenge. We are going to be expecting him to join, but while he joins, please let me use this period to recognize Professor Adamu Bakari Giri, former Dean of Medicine in ABU and current Provost of College of Medicine, Modibo. We really appreciate your presence here, sir. You are highly welcome. We love you, and we believe that you're going to be having a wonderful experience with us as well. So I think Dr. Samuel is having some technical issues. Great, he's back.
I am back. Am I still audible?
Yes, please.
Since I joined. Yeah, maybe because I'm in the radiotherapy facility, the network is not so good. It keeps tripping up every 5 minutes, and I have to always ask the admin to let me back in. I was just recognizing Professor Ahmed, whom I was his house officer some years back. I see a lot of my classmates, Mojid Onadiran, Miss Guy, Mohammed, Ibrahim Zaria. I felt I should at least recognize some of you. And Dr. Kajobola is my chief medical director. If I don't want my October to come in December, at least I should recognize him. But let me just quickly go to the business of the day. It's a good thing that we decided, while talking about rebranding the health system in Nigeria, to talk about cancers, because From the very look of things, the majority of the Nigerians that find their way to India, Egypt, South Africa, and all those other countries out, medical tourism, most of them go because they have cancers. And maybe we should begin to look at it from that area, because it's one of the areas that is seriously untapped in this country. My job is a simple one. It's just an overview. And I am going to beg my teachers who are on this platform to just pardon me for trying to be as simple as possible, because this lecture is more for the purpose of those who are non-doctors on the platform, not those who already know far more than I do. So what are cancers? I will be very conscious of the time, like I said. Cancers can be considered as an unregulated proliferation of cells. It has three major hallmarks or cardinal features. One, there is uncontrolled growth. Two, there is invasion. I will explain what that means. And three, there's metastasis. I'll also explain that. But basically, the moment you have an unregulated growth of cells, you're talking about cancers. So we must just go back. If we want to understand the concept of cancers, the simplest way to start is to ask ourselves what the cell is. Now, the cell in the human body and in every living system is the simplest unit. That means if you take a human body, you keep breaking it down, the simplest bit of that human body that can still survive is what is called a cell. Now, it's very important because everything that happens with regards to cancer starts up from that level, which we call the cellular basis. The human body, well, I was just saying that the human body is made up of about 32.7 trillion cells. Now, if you look at the population of the world, we're somewhere between 7-8 billion, not trillion. So when you consider the human body, 5,000, and that is as many cells as are in the human body. But the reason why I'm giving these numbers is simple. These cells are usually so well coordinated in their actions. When we were reading biology, when we were growing up and reading biology, they used to talk about Mr. Now you see, every one of these 37 trillion cells, they are so well coordinated. How long they are going to live, how many times they are going to reproduce, how large they grow, everything. They carry out their nutrition, they carry out their respiration, just the way a full human being carries out all of these functions. So you're talking about a human being is like a walking world of over 37 trillion cells, well coordinated. In fact, they are so well coordinated that if you take the cells from one part of the body and just transplant them to another part of the body, the cells in that new part of the body are likely to recognize it as foreign. It's coming from the same body, but you take cells from the leg and transfer them to the lungs. The cells of the lungs will kill it because they recognize it as, this is not one of us. That is how so well they are coordinated. In fact, they are so well coordinated that they exhibit what we call contact inhibition. When two cells are growing together, close to each other, the closer they come together, the slower their growth becomes, such that at the point that they just come in contact with it, that is how well coordinated they are. Now, why are we explaining all of this? Because the cancer cell is now a singular cell that suddenly decides, for certain inexplicable reasons, to defy all of these natural checks and balances that have been placed to regulate cellular activities. So you see a particular cell that doesn't die when it's supposed to die. In fact, some of them become immortal, that suddenly doesn't stop reproducing, that keeps growing without any due regard for the normal checks and balances that have been placed in nature. And the worst thing is that this cell also now has an ability to leave any part of the body where it started to go anywhere else. That is what we call metastasis. And when it gets to that place, it suddenly becomes the landlord. So when under normal circumstances, it's supposed to be killed by the cells there, but in this case, it suddenly becomes the landlord. Now, like I said, I have to speed up because in another few minutes again, the network will trip up. What causes this sudden change in the character of the cells that makes them suddenly start growing without control, without dying, reproducing on a continuous basis and all of that? Unfortunately, we do not know. In essence, I'm saying that if we're talking about the cause of cancer, what makes a cell become cancerous, the medical world is still struggling to find that out. And you see, once you know the cause of a problem, you are halfway through solving it. One of the reasons why we now have a vaccine that helps to significantly control cancer of the cervix is because we have gotten to realize that there is an infective agent that is responsible for over 90% of cancers of the cervix, human papilloma virus. So it becomes easy to just get a vaccine for HPV and curtail that disease. So if only the exact thing that is responsible for switching cells from obeying nature to become vagabond cells that become cancerous cells, if we know that reason, we're halfway through solving the problem of cancer. But unfortunately, we still do not know that reason. So basically, we do not know the exact cause of cancers. And because we do not know the exact cause of cancers, we rarely describe a cancer in terms of its cause. We know, for instance, that smoking, lung cancer occurs more commonly among smokers. You know, over 90% of lung cancers would occur in those who smoke. But if you say cigarette smoke is the actual cause of lung cancer, then the person who has never smoked in his life, who makes up that 10%, would ask you where he got his cancer from. So it's still difficult for us to place our finger on the exact cause of cancer, but we talk about predisposing factors. Now, predisposing factors are those factors that make an individual more likely to get cancers. There are so many, and they vary based on the cancers we're talking about. In fact, to compound this confusion, predisposing factors for one cancer could actually turn out to be protective factors for another cancer. Let me give you an example. Cancer of the breast and cancer of the cervix are the two most common cancers in women in the world, right? Now, we know that having multiple children, you know, multiparity, helps to reduce a woman's chances of developing cancer of the breast. But that same multiparity is a predisposing factor for developing cancer of the cervix. So if you live your life by a checklist of predisposing factors and protective factors and say, I want to be doing this because it will not increase my chances, I want to avoid that because it will increase my chances. The truth about it is that these factors crisscross each other depending on what cancer you are talking about. But basically, we could divide predisposing factors to cancers into two. There are those factors that we can control, and there are those factors that we have definitely no control whatsoever on. Factors that we can control, for instance, things like exposure to certain chemicals that could be responsible for cancers, things like smoking, things like heavy alcohol intake, things like our weight, you know, obesity, things like sexual history, things like having unprotected sex, things like undue exposure to the sun if we are light-skinned. You know, these are all factors that we can do something about and thereby reduce. I hope I'm still audible because there's a lot of noise that is hitting my ears. But at the same time, there are non-modifiable risk factors. There are certain cancers that are more common in an individual just because the individual is a male or a female. Breast cancer, for instance, 99% of breast cancers occur in women. Now, the fact that they are women is natural, and they cannot change that. So there are certain factors. I hope I'm still audible. There are certain factors like sex, like age, like genetics, like family history. Thank you. Those factors are things we can really do nothing about. So we always look at the risk factors for breast cancer as either modifiable factors or non-modifiable factors. But I am just emphasizing this to make us realize that no matter how much we modify the modifiable factors, a significant number of factors are still there that we can really do nothing about. And that way, they still predispose every individual to the possibility of getting a cancer. Basically, developing a cancer or not developing a cancer is a complex interplay between nature and nurture, between our genetics and the environment that we live in. I will speed on because I think I've even taken half of the time already. and just talk about what are the symptoms of a cancer. Now, because a cancer can occur in any part of the body from head to toe, wherever there's a living cell, there's a possibility of developing a cancer. So generally, the symptoms of cancers are highly variable based on the exact site you're talking about. If you're talking about breast cancer, for instance, you would start talking about maybe a lump in the breast, some discharge from the nipple, some deviation in the nipple, changes in the skin of the breast, and all of that. Now, all of these symptoms are likely to differ significantly if you're talking about cancer of the cervix, for instance, because the cervix is way down, so you are more likely to start expecting things like pain during sexual intercourse. You are likely to expect things like vaginal bleeding, foul-smelling vaginal discharge, and all of that. And even for men, for instance, if you're talking about cancer of the prostate, things like difficulty in passing urine, hesitancy when passing urine, you feel like you want to urinate, but you get to the toilet, the urine doesn't come, blood in the urine, blood in the sperm, and all of that. I'm just noting all of this for us to realize that the symptoms of cancer vary based on the precise site, the precise type of cancer we are talking about. So if it's cancer of the colon, for instance, the person begins to see blood in the stool, have difficulty in passing stool, constipation alternating with diarrhea, and all of that. But commonly, most of the cancers have features like a swelling, some pain, some ulcer, and all of that, but they vary based on whatsoever site we're talking about. Now, we talked about metastasis earlier, saying that cancers would move from one place to the other. So there are situations where the first thing the patient actually presents with are even signs and symptoms of a metastasis. So these also vary because it depends on where the cancer moves to. If it's the lungs, for instance, the patient could just present with cough, maybe coughing out blood or something, and you would have to dig deeper to realize that the cancer started very far away from the lungs, but the features are there now in the lungs. If it's the brain, things like headache, things like convulsion, seizures could occur. If it's the bone, things like severe bone pain or even pathological fractures. The bone easily breaks for reasons that ideally a bone shouldn't break. The person sustains a fracture and all of that. So it depends on how a cancer patient will present depends on so many factors. In fact, there are symptoms that we just call constitutional symptoms. Cancer could just come with weight loss, unexplained weight loss. It could just come with loss of appetite. It could just come with a general feeling of unwell. It could come with some unexplained fever or anemia, that's low blood and all of that. So the fact I'm trying to get to is that cancers could present in different ways. So I'm going to move quickly to what we do when we see somebody that we suspect has a cancer. Like we said, this is just an overview. So I'm trying to be brief and to hit on each of the points as quickly as I can. Now, we actually break the investigations we do. When a patient comes to see the doctor and the doctor suspects the cancer, apart from the history that we take and the examination, we also do certain investigations. It's easier to break these investigations into 4 major parts. There could be more. But first of all, we want to do certain investigations that will help us strengthen the suspicion of the cancer and try to localize where it's likely to be. So there could be radiological investigations like ultrasound scan, chest X-ray, or X-ray of the part in question, things like CT scan, MRI, and all of that. Those ones only help us to strengthen our suspicion. But there is a second step, which is just the major step that helps us to confirm whether it is a cancer or not. That step is called a biopsy. It's called a biopsy, and a biopsy involves taking a part of the tissue that we suspect to be cancerous and examining it under a microscope. Because like I mentioned earlier, everything about cancer starts at the cellular level. If you do not examine the cells, the tissue at that cellular level, you will not be able to specifically describe the type of cancer. I'm mentioning this because a lot of patients go to the hospital and spend a lot of time waiting to, they've seen the doctor has taken a tissue and he's spending 1 week, 2 weeks, 3 weeks, and they keep wondering, why am I not being treated? Now, that's because the doctors, the oncologists who are specialists that manage cancer, would find it difficult to decide precisely what treatment to give if they do not know with certainty what tissue that cancer came from. I will explain that as we go a little bit along, but just like I said, we are moving. So when a biopsy is done and it has confirmed a cancer, certain things must still be done because we must do some more investigations to find the extent to which that cancer has spread. If the cancer started from the toe and it has gotten to the liver, for instance, and you focus on treating the toe, the patient will come down later on with features of the liver. In essence, you have not done anything because the patient still gets to die from the same disease you claim you have treated. So you must do certain investigations. Some of them could be things like what we call a PET CT, a positron emission tomography, CT scan, and all of that. They could still be the same CT scan that we mentioned earlier or MRI, but more widespread now because you are checking other sites that are distant from where you primarily know the cancer started from, because you want to find out how far it has gone. Then finally, there are other investigations you need to do that give you an idea of how strong the patient is and his or her ability to withstand whatsoever treatment you would want to administer to him or her. So you want to find out what other comorbidities, for instance, the patient has. Does he have a renal problem? Does he have diabetes? Is he hypertensive? To what extent have these comorbidities affected his system and his ability to withstand whatsoever treatment you want to give? Very importantly, before I go to treatment options, I must just mention that we stage cancers, and there are so many good reasons why we stage cancers. Cancers are usually staged because it gives us an idea of how far the disease has gone. That helps us to determine what modality of treatment we would use, and it also helps us to prognosticate. Prognostication, having an idea of what the likely outcomes of this treatment could be. So every doctor that sees a cancer patient prognosticates and starts giving himself an idea. Well, most patients with this cancer and this stage will not live beyond 10 years or beyond 5 years. So how do I help the patient accommodate all of these things that I expect could happen within this specific time frame that I just mentioned? So all of that is important. And that's why for every cancer, after we've done all of those investigations, we still have to go ahead and stage. Most cancers are staged 0 to 4. A few cancers actually have a fifth component, so they are staged 0 to 5. But the basic thing I'll mention about staging is the fact that as the number increases, the cancer worsens. So a stage 0 cancer is far better than a stage 2 cancer, and a stage 2 cancer is far better than a stage 4 cancer. To simplify things, we could just classify cancers as early or late, where we will say maybe stage 0, 1, and 2 are early, stage 3 and 4 are late for most cancers. But that is just to generally simplify things. But cancers are usually staged 0 to 4 or 0 to 5 in some cases. So when we've done all of this, what are the treatments to us? You see, that is where cancer treatment differs significantly from maybe, do I say, treating an infection. If an individual has an infection, maybe with a bacterium, because the bacterium is foreign, that bacterium is likely to have something in its system that is very important for its metabolism and survival that doesn't have anything to do with the human body. So if that thing, if that system, if that metabolic pathway is identified, it becomes easy because all you need to do is administer a drug that blocks that metabolic pathway, directly, specifically affecting the bacterium while not in any way significantly affecting the human body in which you are treating it. That's why we talk about culture, sensitivity, but all of that we can only do for conditions. But here we are with a cancer that starts from within the body itself. So it is a little bit more complex in this case because almost everything that the cancer cell depends on to survive is that same thing that the normal cells from that same part of the body depend on to survive. So treatment of cancers become a little bit more complex. Apart from surgery, we all know what surgery is. Take the patient into the theater, yank out the diseased portion with a knife. That is that one treatment that does not really care so much about the biology of the cancer and all of that, because you just see the disease, and if you are able to take it out in block without significant damage to normal tissues, you do that. So surgery is one treatment option for cancers, but there are other treatments. One of those other treatments is radiotherapy. Now, radiotherapy uses what we call ionizing radiation. Ionizing radiation are, very high energy radiation, maybe from X-rays, photons, from protons, and all of that. But what they are able to do is actually kill every living tissue that comes along their path and gets a significant dose of the radiation. So radiotherapy is one of those treatment modalities for cancers, but it is a treatment that has to be highly focused. You have to be able to localize exactly where you want your radiation to hit, and how much dose. So I was talking about radiotherapy, and I was talking about radiotherapy has to be precise because it delivers a treatment modality to significantly harm other surrounding normal cells. Now, chemotherapy is a third option for treating cancers. And what chemotherapy does is mainly to try and figure out one thing that is different about these cancers and hammer on it or attack it. Now, what we have said about cancers from the beginning is that they grow rapidly. Because they grow rapidly, there are chemicals they produce that they depend on to keep growing. They must produce certain things in their DNA, in their chromosomes. They must keep replicating. So most chemotherapy agents actually attack the growth process of the cancer cells and are able to kill cancer cells. They are given either as intravenous drugs or as pills that patients take. But you see, the problem with chemotherapy is the fact that it is not specific. It is targeting growth of the cancer cells. It's targeting cancer cells because they grow rapidly. But there are other cells in the body that also grow rapidly by virtue of how they are. Cells of the intestinal tract, for instance, are on a daily basis. Cells in the bone marrow, for instance, that produce our blood are also rapidly dividing on a daily basis. So you now wonder, it's a no-brainer that once you start giving a patient chemotherapy, most of those cells that are rapidly dividing cells will be those first cells that will be hit with the side effects of your chemotherapy, because the same way the chemotherapy is attacking the cancer cells because they grow rapidly, it is likely also to attack rapidly dividing normal cells within the body. So it was eventually taken a step further because of the non-specificity of chemotherapy and the significant side effects. Research had to look a little bit more on cancer cells, their genetic makeup and everything, their structure, and suddenly a few things begin to crop up. We begin to see a few things on those cancer cells structurally that are different from normal cells. And because we see those things can specifically be attacked and used to kill the cancer cells. That kind of treatment is called targeted therapy. So the cancer cells are examined, they are checked under the microscope, they are checked in the lab, and when we see something about them that is different from the rest of the cells in the body, that thing becomes a target, and targeted therapy could now be used. So we've mentioned surgery, we've mentioned radiotherapy, we've mentioned chemotherapy, we've mentioned targeted therapy. Certain cancers actually depend on some hormones in the body to function properly. Cancer of the breast is one of them. Cancer of the prostate is one of them. So for these cancers that depend significantly on hormones to thrive, there is always that option of using certain measures that block or reduce the number of these hormones in the system, because when you do that, you are starving the cancer cells of what they need to thrive. So hormonal therapy is one other option. Maybe I'll also just mention immunotherapy. Usually, cancer cells evade the immune system of the body. And that makes them, they create certain proteins that makes them able to evade the immune system. That is why our body doesn't usually fight cancer cells the way it does with other infective agents when they come in, But what science is doing right now is to find drugs that will help block the formation of those proteins. It blocks the processes that the same cancer cells use in order to evade the immune systems of the body. And as such, these drugs help to upgrade the immune system of the body and help it to fight against cancer. That is called immunotherapy. So I've mentioned at least 6 types of treatment. We've talked about surgery, we've talked about radiotherapy, we've talked about chemotherapy, we've talked about targeted therapy, I've mentioned hormonal therapy, and I have also mentioned immunotherapy. Maybe I will just round up by talking about screening, because that is why I talked about staging. Now, the most important thing about cancer and our ability either to treat or to cure a cancer depends on the stage at which that cancer is seen. If a cancer is caught at an early stage, stage 1, stage 2, the chances of curing patients with most cancers that come in stage 1 or stage 2 is very high. But when they come with an advanced disease, even in the best centers in the world, many patients that come with stage 4 disease know from the beginning. Come on. All right, I think I'm back on. Just 2 minutes and I'm out. Because the stage of a cancer is very important, we try to catch these cancer diseases early. So that's where screening comes in, because screening involves looking for a cancer before the patient even shows any symptom whatsoever. Because when we wait for the symptoms to come, the disease in most cases would already be an advanced disease. So when we screen, we detect diseases at an early stage where they are easier to treat, easier to cure, cheaper, and we use treatments with less side effects. So if there's anything we would take home from this lecture, it is the fact that screening is very, very important. For most of the more common cancers, there are various screening modalities. Some of them involve we are talking about, but generally there are different screening guidelines. At what age do we begin to screen, who gets screened, how they get screened, and all of that. It is good we get ourselves conversant with all of those things, because the hope for cancer cure lies more on screening than any other thing. So what is the take-home message from this lecture? Well, we still do not know everything we need to know about cancers, but I just want to say that majority of cancers are still curable if caught early. The major challenges we have with cancer revolve around late presentation and availability of the facilities we need to carry out a comprehensive treatment. So please, once you fall into the category of certain cancers, please talk to your doctor about screening. Thank you very much. Thank you, C-Health, for the opportunity to at least share some few bits about cancer. And